with no funding really, a highly secure, safe platform for EHR research on a very big scale, and can we do it quickly? It was pretty quickly a partnership, a collaborative between Oxford University with Ben's EBM Data Lab, Prof Liam Smith at the London School of Hygiene and Tropical Medicine, ourselves, and then with massive support from NHS England and NHSX to try and get everything in place from a regulatory perspective. So under COPI regulations, with lots of DPIAs and data sharing agreements flying around very, very quickly, we got to the point where we could build, we got permissions to build a database for all the GP practices on our system and to link some important data sets in, which I'll touch on very briefly. So that meant that we've now got a database for about 24 million primary care electronic health records with linked data in, but in a new format that means we don't have to actually extract any data away. From a sort of analytic platform, I don't know if some of you may not know what we do, but we're an electronic records provider, and about 2,700 GPs, about the same in community care, and then some emergency department, acute hospital, etc. So what we do is store centrally in a cloud infrastructure what we would call that level 1 data, which is completely identifiable EHR data. It's used in routine clinical care in general practice in this circumstance. So when you go to your doctor, that's exactly the information that's been used for them to make good clinical decisions for you. The permissions meant we could build a level 2 version of that, so de-identified version, and we linked to external data sets. So we didn't move that data out anywhere. That data stayed in situ inside that tier 3 data center environment, without us having to start to worry about shifting extracts and all the sort of security and technical challenges that can bring. But again, that's pretty high. You know, it's gone through the de-identification process you'd want, but it's still pretty high dimensional data. You can see event level data as to when someone had a diagnosis, for example, even though it's gone through that anonymization. And then possibly slightly hidden, we wanted to create this level 3 data, which is what the epidemiologists actually want, which is genuinely anonymized, low dimensional data that they can run statistical analyses on, but for which the chances of re-identification are absolutely minimized. So we built that inside the data center, and then, as we say, didn't move anything. So we've got our developers sitting at the TPP side. We've got the epidemiologists from Oxford and London School who know exactly what analyses they want to run, and then crucially, this kind of middle ground, new breed of person, a sort of developer epidemiologist who talks the language of developers but talks the language of epidemiologists. They're a very small group of about 3 or 4 people who can access that level 2 data, but only running big aggregate SQL queries and not drilling down into any detailed rows. They go in over VPN. It's restricted to a certain IP address and a certain MAC address, so we know exactly what device it is. We know exactly where it's coming from. They run those queries and produce the analytic results that are then pushed up to that level 3 data, which is genuinely anonymized and really pretty secure. And even then, a small team of epidemiologists, probably about 15 or 20, can access that data, and all the statistical machinery they need lives inside that infrastructure. So we've never moved any data around at all. What data we've got currently? So I said we've got 24 million primary care records from TPP, from NHSE. We've got the emergency care data and the COVID death data. We've got the national intensive care data set, the death certificates data, and all the positive and negative lab results so far that have gone through PHE. We are hoping to expand that further to answer some more important questions, but for now that's where we are, and we're getting refreshes of that data depending on some of them, but at least on a weekly basis. Key analytic questions really quickly: determine which people are at highest risk of hospital admission, intensive care or death. Can we assess specific hypotheses around certain drugs? 2 big research questions. Moving towards more research and surveillance, can we use that database to do some disease modelling, importantly to do some predictions on local spread and what the service need impacts may be as we come out of lockdown. On top of that, how do we measure and mitigate for indirect health impacts of COVID, the aftershocks of people not being able to access the services they need, the aftershocks of people being in lockdown for so long, and finally, can we use it to evaluate the impact of national interventions, for example, some cluster randomised trials on certain patient groups. We are doing it in the open as much as we can, so all the research output is available on Git and available on the website, so that means all the code lists you need to run this, all the drugs lists you need, the Python code, the Stata code, the notebooks and the papers are all available for other people to use. Of course, we are nowhere near the only research group working in this space. So as much as possible, if we can minimise the technical and the clinical effort that have gone into producing these for other people, we want to do that. So please use those if they're useful. Outputs so far are mainly this paper we released last Thursday. So it was 17 million adult NHS patients and factors associated with poor COVID outcomes. It's there as a preprint. It hasn't been peer reviewed yet. We're expecting to push to that in the next couple of days. On Altmetric, which is kind of a way of saying how much interaction there's been with what's the spread of your work. It's already up into 3,600, which last year would have put it in the top 30 papers internationally. So obviously there's a load of interest in using rich NHS primary care data with linked data to do some important COVID research. My ask, I'll go back to there, the ask really is we're really interested in doing some things around geography, both in terms of risk and in terms of disease modelling. One of the things we'd love to know is household size, and we struggle to do it from routinely collected data. So the question to Paul really was if there's anybody with great geographic open data knowledge who can point us in the direction of a file that gave us, for example, a unique property reference number to household size, or at least gave us an estimate of that, so we can start to look at the impact of cohabitation on COVID spread and of local spread and service needs. I think I've overshot, so I'll stop.
That's amazing, Chris, and fantastic work, and just shows what can be done at pace. And also, if you set up to be open from the start, rather than try and retrofit open to a project. You might see my comment about Zoe, and I'm still to be convinced that was set up to be open from the start. It seems to be pulling teeth to get information out of that. But some good PR anyway for a startup. Maybe I'm being too cynical. Maybe I'm not. So that's fantastic. Chris, are we okay to put these slides up on the Open Data Saves Lives
sure.
website? And that question there about geography, unique property reference numbers, geographic data about size, like we are getting a lot of, there's a lot of common themes coming out about geography and how the UK manages to stuff geography up between its different organisations and institutions. I know Graham Hyde has been on about this. I'm not sure we're going to get an answer straight away about that. However, we are going to put on the data pub page that we're now putting together. At the start of the meeting, I gave Patrick, our data scientist, a job to do, which was to put a Google form on our data platform to ask for data that we don't have, and can we get this data and put it all in one place. So I know there's a number of people looking at geography. I think we might be able to work together to get that done. It is commercially held, but we are in unprecedented times, and maybe we should be saying these are the questions that need to be answered.
Sure.
So I've sort of filled, while people are filling the chat in there, if anyone can help Chris, let us know in the chat. We can share contacts. We're going to put this openly as well. And this is it's just another question. I think there'll be another question about geography in the future that comes up. I know there's a whole thing about vulnerable patients and vulnerability indexes that the Red Cross are working on. There might be some crossover there. So let's help you try and find that answer. And the best way I know to do it is to make it as open as possible, so that we get as many people looking at this question as possible.
Sure, brilliant, thank you.
And this is amazing work, and it's something that we need to tell a lot of people about. And also, I think the approach of being radically open right from the start of a project has been massively helpful to this, in that we're going to get the biggest impact from this work with this approach. So lots to learn. Okay, some good answers in the chat there. Okay, I'm not going to go to Tom yet. Jamie, have you managed to work out the technology from a technologist?
I didn't want to try it. I didn't want to interrupt that presentation then, but I can give it a go. Let's see what.
Good man. See if you can share your screen. And over to you.
Considering I kind of make my money out of technology.
Don't. Yeah.
I hate it.
Yes, I think you're on. Yeah, we're viewing Jamie's screen.
All right. Okay. So you see my Zoom. Great stuff.
Thanks very much, Chris. Over to you, Jamie.
Yeah, thank you. All right, cheers. So so I've kind of obviously introduced myself. So I think that the idea behind this was that that I wrote a blog post which essentially looked at ways of programmatically accessing the data, and I think Paul kind of wanted me to come along and just run through that really quickly, just to see if anybody's got if anybody could make use of it, and kind of demonstrate the fact that opening data up in this way, has the potential to really kind of save a lot of people's effort, because a lot of the effort is put within the government department, and then in theory thousands of people can all make use of that. So this is statistics.gov.scot. This is Scotland's official statistics site, and if I click on data here, then we can see there's a range of data sets, but the one that we're going to look at is this coronavirus COVID-19 management information. I'm not going to go too much detail into the data set itself, but the basic principle is that there's a load of different variables, different measures that they've got in there about ambulance attendances, people in ICU. They've got numbers of people tested, numbers of staff who are absent from hospitals. So it's really quite a big, rich data set, broken down by country and health board areas. But the good thing about it is that we can browse the data in here, and we can download it. So we've got a CSV download button here, which if we click, it will download a CSV file, which I don't know whether this is going to view now, right? Can you see that? Can you see it switch to Excel? Or are you still on? No.
Jamie, I think you just need to choose the window.
So, okay, so I probably don't actually need to do that. So, this has downloaded a CSV file that contains a lot of the data. But what we're going to actually do is, instead of doing that, we're going to right-click on CSV, and we can copy the link address. And because this is a permanent link to our kind of data set, we can do things like in Google Sheets. So we can say equals import data, and put this URL in here, and that will just go and fetch the data. So because this can fetch the data into Google Sheets, we can then make some charts and do some things off the back of it, and we can set Google Sheets to automatically refresh. So if we want that to update itself every minute, Scottish Government publish stuff every I think it's every day about 2 o'clock in the afternoon. They update their data. So they release a statement on gov.scot. So in a similar way to the English government do it, but because they publish their data as well, it's kind of instantly accessible in kind of applications that you've set up to do things like this with. Another way of dealing with this, I'm going to try and switch to how do I switch to a different application? I go in here. And let's have a look at, so this is R now. So R is a kind of a statistical programming language, I guess it is. But the principle here is exactly the same, in that we've got like a little script here. So if you can see this panel here, we're doing some work to go and fetch the data. So you'll see that we've got that same URL in there. So it's going to say, so we're saying, using a particular package, we're going to go and grab that data, do some stuff with it. So we're filtering by geography, we're filtering by one of the variables. We're doing a bit of mutation on the data, and then if we run the whole thing, we can grabbing the data. So that takes a couple of seconds. Run it, do the munging, and then draw the chart. And you can see that kind of quite quickly. It's drawn a chart there. So that's using the latest data that's available on statistics.gov.scot. So this is good for kind of local analysis, I guess. But one of the nice things about R is that you can kind of publish stuff to the web quite easily using a package called Shiny. So if I go back to Chrome, then I can show you that here, if I reload this, get rid of that. So I packaged up that code as a kind of nice little web application that just publishes to the web. So we can see that here we've got properties.shinyapps.io, Scott COVID. Every time somebody runs that, it will go and fetch that latest data from statistics.gov.scot. So the idea is that with this sort of thing, you can build up these kind of dashboards, I guess, or similar, are using the data as it's published by Scottish Government. So it takes care of itself. I guess other examples of this, maybe, I suppose what I'll do, let's see. If we go to Python's probably another decent example of this. So exactly the same way, we're going and fetching the data. So, very similar to R, but if we move that down, we can run this, then it will fetch the data. It will do some more kind of munching of that data until ultimately we end up with another chart, which I'm not sure whether it's going to show on the screen share. So you can see the data itself. I don't know if this might not be being displayed actually. Oh, there we go. So that's just rumbled that chart. So this is, the number of patients in ICU. So again, this is the sort of thing that we could hook up to, say, Flask or similar, and people could then, kind of create these dashboards that again will sort of auto update. Now the reason I've also got a Tableau one as well, but so Tableau is a bit more complicated in that Tableau doesn't seem to connect automatically to data via URL. So we need to write a kind of a connector for this, which I've done. I've put this on GitHub, but if you kind of have a look at the blog post, you can see how it's done. What I guess I'm interested in is I think that this is a really powerful way of publishing data in this way, not just for COVID, but anything where data sets are quite rapidly moving. So this is obviously on a daily basis. Other stuff, that kind of the idea of not having to go and fetch the data yourself, but that you can build stuff that takes care of itself is obviously, it's the way that we want to be going really. So I think, being able to sort of demonstrate this is one thing, but just seeing, if people can make use of this kind of stuff to make stuff that's genuinely useful, would start to, the Scottish Government put a lot of effort into doing this, into, designing the model for the data and going through the process of publishing it on a daily basis at the same time as the information is published on gov.scot. So it'd be nice to give them a bit of love and try and kind of do some stuff that kind of makes use of their efforts. And I think that's probably it from me.
Fantastic, Jamie. I just wanted to. This is a great example of using the web as it's intended in that the data is published, we create great data infrastructure, people can start answering questions, but also if we put it in the open, other people can use that information or code or scripts to answer their own questions, but also build on what you've already done. And it also shows a great use case for why we need to publish more and better data. And that with just some great links in the chat about NHS Futures. I've been invited to NHS Futures and it's just crashed my inbox. It's like going back to the 1990s of chat rooms and email. And we need to use the web. And I don't know why NHS Futures isn't open on the web and why Jamie can't post to it without having to have a password. So we've got some great feedback on NHS Futures. I've tried to engage them, but it seems to have gone on a bit of deaf ears. So I would love NHS Futures just to be a website where people are posting and people are sharing interesting work and not having to broker that through an email or a password and go back to the 1990s. Although I would love to go back to the 1990s because I had a great time. But that's a different conversation. Thanks very much, Jamie. People are asking for your blog posts. So I think if you could post that in the chat, there we go. We'll put it on the web. We'll put it on the web for you.
Cool.
And you can find him at Northern Jamie on Twitter. If you DM him, he will usually come back to you. That's usually the best way to get hold of Jamie.
The only way.
Yeah. But thanks very much, Jamie. And if you've got any questions for him on that, give him a shout. That would be fab. If there's no more questions, Tom, I'd like to go to you next. And
Hello.
Without further ado,
just to start on what Jamie's shown there, I think one of the really nice outputs, and I will write this up so that someone in the Scottish Government can stick it on the wall and be happy about it, is in England we've had a lot of local NHS bodies. I'll always get the names wrong, whether they're trusts, CCGs or whatever, I don't know. A lot of local NHS bodies have had to write letters to the press saying, we don't have a local outbreak, it's just that we've done more tests. Please don't report that we have a local outbreak. There's not been a single one of them in Scotland. And the reason is because on that website that you just showed, you can see how many tests they do in each region. So every health board in Scotland has a test number. So you don't even have to tell the journalist to not write that story, because they just get the data, then they don't write it, and it's problem solved. So that's one of the really nice outcomes that I've seen in the variation of those things. Right, I'll share my screen and see if it works, because I'll talk about what I'm going to talk about. Google Chrome, share. Does that work? I hope so. So I'm going to talk about, I've just taken two clips off Twitter to be the background of what I'm going to talk about. Both of these are good journalists who work with data. And they've tweeted things that are both not incorrect, but I believe that everybody, almost everybody, 95% of people who read them have misunderstood them. So one is Ed Conway's at Sky saying, social care workers face more than 2x the average death rate, but death rates among NHS workers are in line with the average. The other one is National Records of Scotland reveal people in the most deprived areas are 2.3 times more likely to die with COVID-19 than those living in the least deprived areas. We've had similar outputs from the ONS covering England and Wales. And what's quite interesting about them is most people, I think, believe that in England, more people are dying of COVID-19 in deprived areas than in less deprived areas. And that's not true, right? The number of deaths, as far as we have data for in the public, there may be hidden data that shows something else, but in the public, the number of deaths has been equal across all levels of deprivation in England. It's just that the age standardized mortality rate has been higher in the most deprived areas. So that basically means that probably it's younger people that are dying. And I think that we are failing to communicate what age standardized mortality rate means. It can be explained really very simply. Death rate is the number of people per 100,000 who die in an area. Age standardized mortality rate in an area just counts younger people more. So it says that if you're 80 and you die, you count less than someone who's 60 when they die. So I did quite a lot of work using an ONS data release, which released the number of deaths by MSOA in England and Wales from the 1st of March to the 17th of April. And it's split out by indices of deprivation, how many people had died in each indices of deprivation. So one of the first challenges I had was that the Wikipedia page for multiple deprivation is shocking, absolutely shocking. And it basically meant that I knew when I published anything writing about indices of multiple deprivation, no one would be able to understand it because no one would be able to check the Wikipedia page. So before I could do anything, I had to fix the Wikipedia page on indices of multiple deprivation. Now it's pretty good. So I think that most people could understand what IMDs are now by looking at this page. It was not only wrong, it was also awful before. I even did a nice little map that talks about deprivation in Northern Ireland. Picked Northern Ireland because it fits nicely into a box. I'm a bit disappointed by the shape of the other three nations of the UK. So like they're all too tall and thin. I mean, Scotland's a nightmare. Shetland and Orkney just ruin all your maps. You have massively zoomed out. England's really tall and thin. So we've first had to fix that. But now I want to talk about what the actual results are. You can read about all of the analysis on my website here, tomforth.co.uk/coronavirus and deprivation. I talk through at painful length all of the things that I'm unsure about. And the reason was because I didn't want to get called a loser tech bro who should stick to technology and not meddle with biology. Now, I do actually have a PhD in biology, and I did a lot of statistics on infections when I was at uni, but that wouldn't insulate me from the abuse. But you can read here all of the stuff we did to create a data set which is of excess deaths by MSOA, which are small areas of England, and COVID-19 deaths. The result that's really important is this one that you see right in the middle of the screen now. The result is, I estimate that COVID-19 has caused an equal number of deaths in all deprivation deciles within England. And I think what's important to say is that this result is completely in agreement with what the ONS have said themselves. It's just that what the ONS have said has been universally reported as COVID-19 is causing more deaths in the least deprived deciles in England. And the reason for that is that people are not saying that it's age standardized mortality rates. So there's lots of stuff you can do here. The reason that we did this really was to look to answer the question of, is COVID-19 causing more deaths in the least deprived or the most deprived parts of Leeds, Manchester, Bristol, Plymouth, any geography that you want. I have calculated the data that lets you say where there's more or less impact of COVID-19 by deprivation decile within any area you pick. There are some interesting challenges with that in terms of data. My favorite one is the Birmingham problem, I'll call it. If you ask whether anything happens in Birmingham, does it happen in deprived areas of Birmingham? The answer is yes, because all of Birmingham is deprived. And that doesn't tell you anything about the distribution within Birmingham. Basically, all of Birmingham is deprived. So these were the kind of two graphs that I did for Birmingham. So this is at the top, number of excess deaths and from COVID-19 by deprivation decile of Birmingham in the top. And basically what you'll see is that everyone who is dying with COVID-19 in Birmingham is doing so in a deprived part of England. And that's just because all of Birmingham is deprived. But when you create indices of multiple deprivation deciles for Birmingham, that is, you split Birmingham into the most deprived and the least deprived parts, what you find is that the deaths from the disease are spread equally across deprivation in the city. So you get a very different picture depending on what thing you're looking at. And probably if you are Birmingham City Council, you want to understand the impact of this disease, you probably are interested in the bottom one, because it says, basically it says we have to look at this disease across the whole of our city, the whole of our community. All of the code's here on GitHub. I'm afraid that it's in C#, so basically no one will be able to help me edit it and run it and use it. I am a dinosaur of the data world. I'm very sorry. There's also a Power BI visualization, which I've carefully named nowhere near finished, be careful, but actually it's more finished than that sounds. I just didn't want annoying people to deliberately misinterpret what was in there and have no way to get back at them, but it's actually pretty good. So there's loads of data there. The last thing that I wanted to say was there's a interesting detail of this data that exists. So the reason that I was able to do this analysis was one special release by the ONS, which happened on the 1st of May, and it released the numbers of deaths by all causes and by COVID-19 for all MSOAs, which are small areas, 7,000 population each, about of England and Wales. And that was a one-off release, doesn't seem to be being updated. We can do exactly the same analysis in quite a lot more detail, which I have done for France. So this is the last one. Every month, France releases the details of every single person who has died in France. Their name, their gender, their date of birth, where they lived, where they died, where they were born. And from that, you can calculate absolutely everything that you want. So you can calculate excess death rate at any geography that you like in France. The data is updated monthly. It goes back to 1970. It's all open data. It's in CSV format. but with a semicolon as a separator, because French people are going to be French about things. But it's a brilliant data set. So this actually lets you do the kind of live analysis with live updating data that Jamie showed for Scotland as well. So that's me.
Thanks very much, Tom. Really important work, really important understanding about data, and I think it's something that we need to be cautious in the way that people have been using data, and the wish to use headlines to reinforce your political or current standpoint needs to be challenged, and it's very important. I don't think the donut of COVID exists.
Yes, that was what people were asking me. Basically, people were coming to me and saying, Tom, I need you to prove that COVID-19 is hurting the most deprived parts of Birmingham, Manchester, etc., the worst. So I looked at it without wishing to prove or disprove that. And basically, at the moment, with the data we have, we see pretty much, it doesn't care that much. It kills you.
It kills everyone.
It kills you. And if you're in bad health, it will be more likely to kill you. And you are more likely to be in bad health if you're in a deprived area. But it's killing people everywhere.
That's a cheery note to finish
great.
Tom's point there. But it's also very important that we get this as open as possible, and the point of Open Data Saves Lives is to encourage people to work in the open, to share what they have early, to move at pace, which means we don't have repeat questions going on and on and on. I guess there'll be still correspondence going on from lots of different people on different sides of the argument trying to prove or disprove this. And the quicker we get these points in the open and shared is the way that we make progress. Okay. We've got, what time is it now? It is, so we've probably got 5 to 10 minutes. The French data link has been, we'll put that in it's there. And it's also a very important point is let's compare ourselves to the rest of Europe, because let's not kid ourselves. Our view from this work is that probably when you look at France, when you look at Italy, when you look at Ireland, they are publishing better data sets than we are in England, and Scotland's probably a little bit ahead of that. So
a real turn up as well, Scotland. I think it's maybe one of the very few occasions we could say that Scotland has done really quite well on open data. It's not always the case, so it's been quite interesting.
Fantastic. So would anyone like to raise their hand, make a point? You can either do that on the Teams function or do it physically. If anyone would like to join in. Chris Barnes has got a point. So over to you, Chris.
Just on the deprivation point. So that's really important what Tom has been talking about. In the work we've done with Ben, because we've got access to more data that enables us to adjust for things like long-term conditions in deprived areas. We did do a lot of breakdown, adjusting for age and gender and long-term conditions, and we do see there is a trend in deprivation. It's definitely not. It's definitely subtler than is being published, but it is there. I've put a link in the comments to the paper, and on page 11 you can see those hazard ratios, and you do see we broke to 1 to 5, not deciles. You do see an increase in risk even when adjusted in those areas. So when you've got,
and that's definitely true. So you can the method that they use in that paper by Ben Goldacre is these Cox regressions and split outs. They're really good. So my suspicion is that deprivation link will go down once the work is expanded to all excess deaths rather than COVID-19 deaths, because we find a deprivation link when we just use COVID-19 deaths. It's only the excess deaths that push it back to being no link. I'm pretty sure that actually we will see a link emerge back over time. So we can only look at the early data here. So I'm pretty confident we'll see that if you just there's one like chart. What do we call them? TIE fighter charts or something? Star Wars charts. So that it's in that paper. It's brilliant, and there's a clear deprivation factor in.
But you're right. We did only do that against the CPNS in hospital deaths. The ONS deaths are coming next week, I think.
Cool. Nicole, you've mentioned a point about you're looking for the best modelling on R infection rates and future projections. Do you want to just share a little bit more about that? Are you there, Nicole? Okay. My suspicion is that we're all going to be talking about R here. Oh, Joe Minton's waving.
Yeah, just a point about going back to the deaths. Sorry, I think there's currently estimating about 40% of COVID-related deaths are in care homes. In France, it's more like 50. In France, it's estimated between sort of 40 and 90. So looking at someone's address to determine their deprivation is not necessarily all that useful, is it?
Yeah, so I strongly agree with that. And obviously, I was responding to what the ONS did. But additionally, I took the Geolytics open data set and calculated all the MSOAs that contain care homes, and then reran the analysis with all of those deaths removed. You can do even more with the French data because it's on a level of individual deaths. It's each person is in the data set, which is quite interesting, I think, to think about in the UK. We would be very squeamish about publishing. The second you die, your birthplace, your date of birth, your full name becomes open data in France. We wouldn't do that here. But it does say now the place of death. So in the French data, you can remove individuals who have died in care homes as well from the data and normalise for that.
Okay, we'll go back to if Nicole's there, because I think this is really important about modelling R in the future and future projections and also geography. So Nicole, are you there? You might have dropped off. The R projections for the different regions of the UK were published, I think, this week. There's going to be a lot of talk about this, about how we get back in the return. So, but it's also going to be interesting in geography because they use the NHS regional geography, which I'm not sure makes much sense to people who are working at local authorities. So I think there's going to be a whole load of work that's going to be required around getting what is a usable and appropriate geography to publish R at, because I'm not sure a geography that includes Leeds, Hull, and Newcastle is able, if you communicate to people to make different decisions. So that's something that I think is going to be in the future. Louise from Leeds University, you've asked a question there about, I don't know what the Open Safely data is. Maybe you could share with us and ask that question.
Sorry, I thought that was what the work by Chris Bates is called with the data set that they have. Is that right, Chris?
It is, yeah, that's right.
Yeah, my question is about working with the team at Leeds Uni at the moment. We've already got existing data sharing agreements with CQC and workforce data through Skills for Care, and we're trying to look at specifically modelling some outcomes related to care home residents to do with the previous CQC quality ratings and workforce data. What's the scope for accessing the data that you have with Open Safely and linking to those? Is there any ability to do that? We're trying to find identify care home residents in administrative data. It's a bit tricky.
Yeah, so we haven't done that analysis yet, but we have got an algorithm to identify who's living in a care home based on the CQC data, but against sort of raw routinely collected addresses. UPRNs would be very handy again, but we don't have them. Yeah. We think it's pretty good in terms of, we think the precision's quite good. So if we say you're in a care home, you probably are. We think the recall's not great, so we'll definitely be missing some people. We think it's okay. and we're looking to go forward with that. In terms of working on that platform, so all those researchers at the moment under contract to NHSE, we knew as soon as we published we'd get lots of people wanting to help and use it, which is great. At the moment, that is to just go through Ben Goldacre. Ben's and that. So if you just drop him a note about what you're doing, we're picking him up.
So, okay, great. That's awesome. Thanks.
Great. That's a result, I think.
If you need an email address, just let me know.
Yes, please. Thanks.
That's a result. Okay. I'm going to facilitate now, and I'd like to finish under the hour, just as a way of managing our time. If there's nothing else, if anyone else has anything passionate to say, please raise your hand now. If not, I'd like to thank our the people who gave the talks today. If anyone else would like to talk on these sessions, please get in touch with us and let us know. We did put some questions into NHS Futures last week about getting someone who's putting the publishing the R values for the different regions of the UK. So hopefully we'll get someone on next week to talk about that and how we can share that information. It's going to be very, very important that we get that communicated well. And then please join in. And then I'm going to just go over to Patrick to see whether he's managed to meet the test of putting a Google form up in 40 minutes on the website. Patrick, are you there?
Yes, I am. I'll try keep this short. So I'm sure you've all seen our Open Data Saves Live data page, which is powered by Google Document. You can get to that through ODILeeds.org/COVID19. So there's loads of data on there now. It's a really good resource. But I'm sure there's plenty of people who are still looking for data that they can't find, or maybe it's just not published very well. So what I'm in the middle of doing is setting up a Google form, which will sit on this website. And if you need data that isn't already here and you can't find, fill out a Google form and we will publish it. So I have created a Google form. It's not on the website yet because I want to check a few of the things with a couple of people from the team. But that should be on today. And that'll let anyone ask for any resources that need and be able to reach our network to do that.
Great stuff. Yeah, and I think that's good. Thanks, Patrick. We'll get it up. But I think if people could continue to contribute to this Google Sheet and links to data that they're aware of, we can put it on the web. It's then searchable, and then it's a resource for us all to use in the future. So please continue to do that. This has been crowdsourced over the last 6 weeks, and it's pretty good at the moment. So please, if you could carry on joining in with us, that would be fab. So on that, I'd like to say thank you again. I'm going to stop the share, and we can all get on with another happy Thursday.
Thanks for your talk, everybody. It's been really interesting.
Great stuff.
Thanks,
thank you.
Cheers.
Guys, thank you.